Good morning, my dear colleagues. My name is Andrei Varvinsky. I'm a consultant anesthetist at Torbay Hospital in the southwest of United Kingdom. And today I was given almost an impossible task to tell you all about regional anesthesia blocks for upper and lower extremities in 40 minutes. So obviously I will have to choose the most important, in my opinion, on this occasion to tell you about. If you are to come to my regional anesthesia course, this will be the program for the upper limb. It will take totally 2 hours, and we will talk about innervation of the upper limb, brachial plexus block, um, with all different approaches, cervical plexus block, blockade of the suprascapular nerve and axillary nerve, clavipectoral block during operations on the clavicle, and nerve blockade of the upper arm at the elbow level, namely median, radial, and ulnar nerve. By the way, this course is available for you to download through uh, uh, educational platform MedVoice. But we are going to talk about those who are underlined here today. We talk about innervation of the upper limb, brachial plexus block, and nerve blockade of the upper limb at the elbow level. Right. What I want to tell you first about, because the first part of the presentation is about upper limb, and the second is about the lower limb. And the further away nerves are from the center of the body, the whiter they are, the more dense they are. In other words, they have more connective tissues. That's why they look whiter, like the femoral nerve on the right side of the screen, and the brachial plexus on the left side of the screen. You see black dots. They look black. They look like vessels. But if you obviously press the probe against them, they're not going to be squashable like arteries, and particularly the veins will be. So the more peripheral nerves, the more white looking they are, and the more proximal they are, the more darker looking they are. Okay, so let's talk about brachial plexus anatomy a little bit. We're interested of the level of a cricoid cartilage, i.e. C6, and there's several important structures there that can help us. So it is a famous triangle. The lower part of the triangle is formed by a clavicle, and in the middle of it is the subclavian artery. The medial part of the triangle is formed by a sternal head of the cleidosternomastoid muscle, and the lateral is made by the trapezius, and then you have a clavicular head in the middle of the sternocleidomastoid muscle, and lateral to that you will find the interscalene groove. This is where you will put your probe, or if you're still doing the anatomical landmarks, that is your level, and the horizontal level is the C6, the cricoid cartilage. And the anatomy of the brachial plexus is classically divided into several parts. So we start with roots. It's formed by the roots from C4 to T1 classically. In some books, you'll find that they talk about T12, giving another little branch to contribute to the plexus. Then it divides into three trunks. Not divides, it merges into three trunks: superior, median, and inferior trunk. Then it divides, each trunk divides into two divisions, and it forms 6 divisions at this level that is already below the clavicle. And then divisions again merge into 3 cords: lateral, posterior, and medial cords. And then eventually they will give terminal nerves, terminal branches. And the most important of them are indicated here. It is musculocutaneous nerve, axillary nerve, medial, radial, and ulnar nerves. However, we can divide all the nerves that are derived from the brachial plexus into short nerves. They innervate the soft tissues and the bone structures of the upper shoulder girdle, and the long nerves, those who run along the arm, innervating the skin and the muscles located there. So among the The short nerves is the dorsal nerve of the scapula, is the axillary nerve, long thoracic nerve, subclavian, subscapular, suprascapular, subscapular, thoracodorsal nerve, lateral and medial thoracic nerves, and the long nerves is median, uh, radial, median cutaneous nerve of the arm, median cutaneous nerve of the forearm. Okay, let's speak about the approaches to the brachial plexus. We have several approaches. One is the top one, the most high one is the interscalene approach, the very famous one. Then we have a supraclavicular approach, then we have infraclavicular approach, and then we have auxiliary approach. Okay, we're going to speak about some of them today. Let's speak about the interscalene brachial plexus approach first. Um, at this approach, this is the skin coverage, by the way. It doesn't cover the median part of the arm and forearm. And you can reliably block C5 to C7 routes here. Ulnar nerve, which derives from C8 to T1, is not blocked by this particular approach. And you would give to overcome this problem, you would give the increased volume up to 20 mils, and would use a low axis intermediate between interscalene and the supraclavicular approaches. So the indications for this block is normally operations on the shoulder region, rotator cuff repair, subacromial decompression for impingement syndrome, shoulder arthroplasty, ligament tears, and lateral clavicle. That's the indication. It's not for the distal operations on the arm because it doesn't cover all the nerves. So in this interscalene block, body position will be on the back, head turned to the opposite direction. You would use a short needle, 50 millimeter needle. Insertion depth is quite peripheral, so insertion depth is only 1 to 4 centimeters, and your needle should be in plane. And target is between C5 and C6. You can see on the screen that you have a medial scalene muscle, you can have anterior scalene muscle. This is stanocleidomastoidal muscle, this is internal jugular vein. This is C7, and this is C7 transverse process, and that's your needle approach between medial scalene and anterior scalene muscles. The choice of anesthetic for analgesia is 0.25% levobupivacaine, 15 to 20 mils. For surgical anesthesia, I normally use 1% lidocaine with 1 in 200,000 adrenaline. A maximum dose of lidocaine is 3 without and 7 milligrams per kilo with adrenaline. The maximum dose of levobupivacaine is 2 milligrams per kilogram. And remember that if you're using ropivacaine, you need to use more concentrated solution because ropivacaine is the weaker anesthetic compared to levobupivacaine and indeed bupivacaine. Okay, so this is the anatomy, sonographic anatomy. The brachial plexus looks like what we call a traffic light. So you have these black dots, one underneath another, between median and anterior scalene muscles. Okay, here's the traffic lights. Here's some other important structures. Anterior and median scalene muscles, C4, C5, C6, C7, and then we have carotid artery, and then we have a internal jugular vein. Right, so you would put your scan on the clavicle, and then you will move it up first. Okay, so what will you see on the screen when you scan it up from the clavicle? First on the screen, you will see the clavicle, you will see the pleura, you will see pulsating subclavian artery. Okay, and there you see I'm moving the probe up. This is anterior, this is a median scalene, muscles, and in the middle you see your brachial plexus. Okay, there's the traffic lights. Let's have a look how it's done. Right, so we are on the clavicle, pleura, pulsating artery, and now plexus in this position. Then we move the probe up to C6 level, and then we'll see our muscles there and there, and there's the groove between them, and then the groove. Now this is the carotid artery in the median part of it. This is our path of the needle. We aim for C5, C7 region, so the upper region first, and then we inject into the groove between anterior and medial interscalene muscles. Okay, complications of this block include phrenic nerve block, quite often happens, because as you can see, phrenic nerve block is nearby at C4, C5 level. It happens quite a lot. Recurrent laryngeal nerve block, puncture of the external or internal jugular vein or even carotid artery, puncture of the vertebral artery, epidural subarachnoid administration, pneumothorax, very rare, and Horner's syndrome happens quite often, which consists classically of the three symptoms, ptosis, meiosis, and anhydrosis, because of the sympathetic trunk blockade. Right, supraclavicular approach, sometimes known as the spinal anesthesia of the upper extremity because it blocks everything. A supraclavicular approach, anatomical landmarks described classically by Kulenkamp and Persky, and the needle was inserted above the middle clavicle where the pulse of the subclavian artery could be found and directed medially to the spinal processes of T2, T3. That's how they described it. It got a high risk of pneumothorax without ultrasound. And after the first description of this block in 1949, enthusiasm then first decreased, and its revival with the introduction of the ultrasound. It provides the anesthesia and pain relief for upper limb below the level of the shoulder joint. So it's not good for shoulders, but below the shoulder level is very good. For elbow, hand surgery covering all the terminal branches. So anatomical landmarks, anatomical landmarks is the lateral attachment of the sternocleidomastoid muscle to the clavicle itself, and the patient's midline. The injection point is cranial to one finger above the clavicle. Okay, so your needle is first perpendicular to the skin, then rotated and advanced parallel to the midline. You usually use the current, stimulating current of about 0.8 milliamps. And when desired response is received, twitching of the fingers, the injection without reducing of the current strength could be administered. This is quite a unique characteristic of the supraclavicular approach. There is no need. One study found that the onset, duration, and success rate of the supraclavicular blocks were not affected by the decreasing of the nerve stimulator current below 0.9 milliamps. So normally we would start with about 1 milliamp, and then we decrease to about 0.3, 0.5 milliamps. And if it's still twitching within the nerve, then we will withdraw a needle a little bit. For this particular nerve, there is no need. So useful tips for this block: the lateral border of the sternocleidomastoid muscle runs in a straight line from the mastoid process to the clavicle. The needle is inserted in a direction parallel to the midline. The needle should never be inserted deeper than 2.5 centimeters unless there is tuition of the brachial plexus. The injection is carried out slowly with frequent breaths while carefully monitoring the patients to prevent the pneumothorax. If pain or abdominal pressure is felt at any time during the injection, the needle should be withdrawn 1 to 2 millimeters. Okay, so this is the sonographic anatomy. You have an artery there and the brachial plexus. You got two. You normally do 2 injections of 10 millimeters of 0.25% levobupivacaine. This will be my choice. Let's have a look. We are scanning now, and we can see our carotid artery. Sorry, subclavian artery with a First rib behind it, below it, and then this is our brachial plexus. Okay, you do not go below that level because this is the high risk of pneumothorax with this block. Muscle, artery, trunks of the brachial plexus. And it's your needle path. Goes underneath first. You inject your first portion, 10 mils underneath, and then the second portion above. Okay, here's the injection of a local anesthetic. That's your needle path. You, like I said, underneath first. Do not go below the white line, below the first rib, and then the second path is above. Okay, and the local anesthetic injection, when you inject, will bring the brachial plexus up first. That's why you do the lower one first, to bring it up the screen. Okay, so now we speak about the needle blocks of the upper limb at the elbow level, median, radial, and ulnar nerve. These are great nerves for operations on the hand. They can also act as rescue blocks. That is when the brachial plexus block has not quite fully worked on one particular nerve. So you will supplement by blocking the particular nerve after you've assessed the quality of your brachial plexus block. Pain and recovery room from the anesthesia in the area of one of the nerves. That's the main indications. So the major nerves of the forearm are, like we said, radial, medial, and ulnar nerves. And also we have lateral cutaneous nerve of the forearm and medial cutaneous nerve of the forearm. So let's talk about radial nerve. It's best visualized over the lateral surface of the elbow, located in the interfascial plane between the brachioradialis and brachialis muscles. In this position, both the superficial and deep branches of the radial nerves are blocked. Okay, so anatomy. Here's the anatomy. Left is the lateral side, right is the medial side. This is the nerve there. This is your bone, humerus bone. You've got triceps, brachioradialis muscle, humerus, brachialis muscle, and here's the nerve. Quite big and very easy to spot. Right, okay, let's have a look how it's done. Here's our needle approaching from the lateral side to the nerve. There it is. Here's our nerve. Brachialis muscle. 3 to 5, and then below is the bone. 3 to 5 mils. Do not be scanty with the volume of anesthetic. Inject at least 5. Medial nerve, probe position. And this is, you can see, this is the elbow. This is the medial side. This is the lateral side. Medial nerve can be found right in the middle. That's why it's called median nerve. Very easy, again, very easy to find. This is radius bone. This is the radial artery, and medial to that will be a median nerve. Let's have a look how it's done. Here's our needle approaching, not touching the artery, and here's the nerve. Again, very, very easy to spot. If you that's the first nerve to learn how to find with the ultrasound probe. Take the ultrasound probe, put it in the middle of your forearm. You will see it there straight away. Okay, there it is. We blocked it. Ulnar nerve, you just, from the pretty much the same location, you move it a little bit more to the medial side, and you will find the medial nerve. Again, you will see the pulsating ulnar artery there, and then you will see the ulnar nerve. All right, okay, here it is. Let's see how it's done. From the lateral side, we're approaching it, and it's again very, very visible. And note that it's quite white because it's also a fairly distal type of nerve. Right, again, 3 to 5 mils. I always use 5 mils, so because the volume is your friend. Tips for the upper limb blocks. It is quite important to insert local anesthetic into the fascial sheath, not into the muscle. Combine brachial plexus with a short-acting agent, lidocaine, with a distal block for a long-acting bupivacaine. So if you have to add something, add bupivacaine. Don't be afraid to supplement if your brachial plexus block is not entirely successful, with blocks within the individual nerves on the forearm level. If you are to use tourniquet, it's painful. The block itself will not cover the pain caused by the tourniquet, so you require analgesia plus minus sedation. Be wary of the phrenic nerve block, especially in obese patients and patients with concomitant pathology. That's why never do the interscalene block on both sides. So let's talk about the blocks of the lower extremity. On the lower extremity, again, on that course that is available through MedVoice, we have innervation of the lower limb, which we're going to talk about. Then we talk about the block of the femoral nerve, the block of the fascia lata, block of the lateral cutaneous nerve of the thigh, pericapsular blockade of the hip, blockade of the obturator nerve. We talk about the blockade of the adductor canal or the saphenous nerve block, and we talk about the sciatic nerve, 2 hours, and also the IPAC, the quite new IPAC block. And also we speak about the ankle block, the blocks on the level of the ankle. Again, this is available for you on the MedVoice to download. So basically, the innervation of the lower extremity is fairly straightforward. So you have two major nerves, femoral nerve and the sciatic nerve. Where do they come from? They come from the lumbar plexus. The lumbar plexus is formed by T12 to L4 and the sacral plexus. But let's talk about the lumbar plexus first. The lumbar plexus gives branches to form intercostal nerve, ilia hypergastric and ilia-inguinal nerves that we can block for the hernia repairs, and L2 to L4 gives rise to genitofemoral, lateral femoral cutaneous nerve of the thigh, femoral nerve itself, and obturator nerve. So these are the major nerves from the lumbar plexus. Fascia iliaca is the fascia that will have in it all the three nerves that we are interested when we are blocking the anterior part of the leg, and they are femoral nerve, obturator nerve, and lateral cutaneous nerve of the thigh. So the fascia lata block, the anatomy of it is here. So we have first we have a femoral vein, femoral artery, and nerve, and the abbreviation for that is VAN. You know, like a driver van. So always from medial to lateral is VAN. If you go from lateral to medial is Navy van. Then we have iliac muscle underneath the femoral nerve. Then we have a psoas muscle, and this is the fascia lata. This is fascia lata on the top, and this is fascia iliaca. So for us to inject underneath the fascia lata, we will need to go through two fascias. Hence, we will have two clicks. Click, click, and we will be under fascia lata if you are doing it without ultrasound, which is quite possible. So all these three nerves lie under the fascia lata, lateral femoral cutaneous nerve, femoral nerve, and the obturator nerves. They're all under fascia lata. This is a slightly incorrect position of the lateral femoral nerve of the thigh. So the distribution for this block is quite large. The nerve distribution, the cutaneous distribution, and the bony distribution, and this is the nerve that this is the block that is truly 3-in-1 block, providing you give enough volume, unlike the classical 3-in-1 block, which was described in the past. So indications for this fascia iliaca block is pain relief for hip, femur fractures, hip surgery, or pain relief after hip surgery, above the knee amputation, plaster application in children with hip fractures, operations on the knee joint in combination with a sciatic nerve block, and arterial tourniquet during the conscious regional anesthesia surgery. Technique, you will have your patient supine. You will put your probe at the level of the femoral fold, not the inguinal fold. There is a difference. Inguinal fold is higher than the femoral fold. Needle length, depending on the type of the method that you would use, is 50 to 100 millimeters. Normally 50 millimeters is enough, but if you, well, make be aware that there is also 80 millimeter needle available, and for that I'll probably choose 80 millimeters because it could be quite a long path of the needle, and doing the needle approach in plane is always better than out of plane. It's not that deep, 2 to 4 centimeters. Local anesthetic I would choose. It's a volume kind of block, so you need at least 20 millimeters of a 1/4% levobupivacaine, a 1/4% bupivacaine, or a quarter or 0.5% of ropivacaine. And target is the space underneath the fascia lata. So anatomically, you can do it. The beauty of this block, you can do it without the ultrasound. So you measure your anatomical landmark is the anterior superior spine, okay, ISIS. Then you have your artery. Then you have a pubic tubercle. So you would go one finger above the artery and below that line, and that will be your injection point. So you'll put your needle quite perpendicular, pretty much. There you go. You have one fascia to penetrate, another fascia to penetrate. Click, click, 2 clicks, and you are there. They're quite visible. Quite not visible. They're quite tactically. They're quite easy to feel those clicks. If you are doing it just with a normal needle, blunt it first. So in the sheath of the needle, blunt the tip of the needle, so those clicks will be even more prominent. So under the ultrasound guidance, this is how we put the probe with an infra-inguinal approach. You will see the inguinal ligament there. This is femoral nerve. This is femoral artery. This is iliaca muscle underneath the femoral nerve and the inguinal ligament. This is lateral side. This is medial side. Okay. And the target space is under the fascia iliaca. This is the spread of the local anesthetic, an extension of the local anesthetic to the femoral nerve medially, and the sartorius muscle laterally. This is sartorius muscle. Okay, and we want that spread there for the sake of the blocking of the lateral cutaneous nerve of the thigh. Complications, nerve damage, intravascular administration. This can happen with any type of nerve block. Infection, particularly if you put a catheter. What are my advices, my tips? The probe can be at any level between femoral and inguinal folds, pretty much. This is the block for analgesia, not for anesthesia. So this is as I said, a volume block. You need a large volume, and with anatomical landmarks, your success is nearly 100% for femoral nerve, 80% of the lateral cutaneous nerve of the thigh, and about 30 to 20% for the obturator nerve. Hence, it makes sense to do this block with ultrasound guidance. So this is your anterior superior iliac spine at the top on the lateral side. And this is with the ultrasound, you do supra-inguinal approach. Let's have a look how it's done. You put the probe there first, and then you move it down a bit. Okay. And your needle, it goes up like that in plane. All right. Okay. Sorry. So this is your injection. It's important to inject a local anesthetic above the iliac inguinal ligament. Percentage of the nerve blocks with a supra-inguinal approach is a lot higher, and this is after 1 hour. So you can see that the femoral, the lateral cutaneous, and the obturator Obturator will be the last one to be blocked, but still with this approach, 75% of the time you will block even the obturator nerve. And that's the assessment after 1 hour, after 6 hours, and this is after 24 hours. All right, let's talk about the saphenous nerve block, or more correctly called adductor canal block. It's the adductor canal. This is the anatomy. The biggest branch that the femoral nerve gives is the saphenous nerve. And this is the area where we would normally block the saphenous nerve. Sometimes it's called subsartorial approach to the adductor canal. Sometimes you hear this block being referred as the subsartorial approach to saphenous nerve. But it's not just the saphenous nerve that is there. There's other few bunch of nerves there. That's why the better term is the adductor canal or Hunter's canal, because Hunter was the first one to describe it. The length of this canal is about 15 centimeters from the top of the femoral triangle down, and it contains femoral artery, contains the vein, saphenous nerve, and nerve to the vastus medialis. So if you are to use electricity, electrical stimulation, the vastus medialis will be twitching when you're approaching your needle to the adductor canal. Indications, removal or harvesting of the saphenous nerve of the thigh, arthroplasty of the knee joint in combination with the infiltration of the posterior capsule, operations on the lower leg and foot in combination with the sciatic nerve. Technique, body position supine, 13 to 15 centimeters above the upper border of the patella. Needle, I would normally choose a long needle, at least 80 to 100 millimeters. Insertion is about 2 to 4 centimeters in plane approach. Pretty much always use an in plane approach. And again, it's the volume block, so I'd use 20 mils of 0.25% levopivacaine. And your target is lateral to femoral artery under the sartorius muscle or directly into the adductor canal. Okay, this is the target. Here we have our femoral artery, sartorius muscle on the top. This is femoral vein. It's quite easy to spot if you just press on the probe. It's squashable. It disappears. So don't go too far below the femoral artery because you will be injected into the femoral vein. This is adductor magnus. This is vastus medialis. Okay. So scanning. Put the probe straight on the femoral bone, and then just move it inwards. And then you will find what you want to find. So when you're scanning from the top of the thigh medially, that's what you're going to see. There was a bone first, then we have pulsating femoral artery. On top of it is the sartorius muscle. This is vastus medialis, skin, bit of fat, vastus medialis, sartorius muscle. Underneath is the adductor canal with the pulsating femoral artery. And here you will find your saphenous nerve. Okay, let's have a look. This is my needle when the probe is in the position I want. Okay, we're turning to the screen. You can see the needle coming from the left. Vastus medialis on the top, sartorius muscle. I'm going underneath my sartorius muscle. I've changed the angle to a more acute angle. Okay. So I'm injecting underneath the sartorius muscle to aspirate first, and I can see how the sartorius muscle is peeling off upwards. Okay. So here it is. It's my needle on the left side of the screen. I'm pretty much touching the saphenous nerve. I'm aspirating, no blood, and I'm injecting. You can see how it spreads. That is even better than the one I've shown you before. The before was acceptable. This is better anatomy on this occasion. And you can see that my anesthetic is not pulling because it's spreading up and down the adductor canal. Okay. Complications common to all other blocks or weakness of the quadruple femoris and the vastus medialis if you use a too high approach, but significantly less than with the femoral nerve block. So use more proximal approach to if you want to pick up all the nerves, including the nerve vastus medialis, or distal approach if you want a complete avoidance of the nerves to the masseter for mobility. If your patient needs to mobilize quite quickly, use a little bit lower approach. There is no need for a clear identification of the nerve. Just inject around the femoral artery or underneath the sartorius muscle, lateral to the artery. So it's very easy to do. And then we finish with the sciatic nerve block. There are quite a few of them described, but I will describe you lateral popliteal approach to the sciatic nerve block. So sciatic nerve derives, it's the biggest nerve derived from the sacral plexus. There is the sacral plexus formed by branches from L4 to S4, and it gives rise to superior gluteal, inferior gluteal, sciatic nerve, posterior femoral, and pudendal block. So it mainly blocks the posterior part of the leg. So sciatic nerve exits from the pelvic cavity through the greater sciatic foramen, passes between the ischial tuberosity and the greater trochanter, and then divides into two big nerves above the knee, and divides into the tibial nerve and common peroneal nerve. And then they give branches to smaller nerves that we can block on the ankle level. But we're not going to talk about ankle blocks today. Again, on my YouTube channel, there is a separate presentation for the blocks of the ankle on the ankle level. It's divided then into tibial and common peroneal nerve. Unreliably, in different patients is different. So it's anything between 50 to 150 millimeters above the popliteal fold. So you'll have to look for this division. For this block, you need to find where this division is. Or in our case, it will be where do they merge back into the sciatic nerve? Because we will scan from the popliteal level up. So the tibial nerve is larger in size than common peroneal and passes vertically, straight vertically through a popliteal fossa. So it's quite easy to find. Terminal branches are medial and lateral plantar nerves of that tibial nerve. And there are collateral branches as well, muscular branches to the gastrocnemius muscle and branches to the ankle joint. The common peroneal nerve descends along the head of the fibula, gives branches to the knee joint, cutaneous branches forming lateral dorsal cutaneous nerve, and its terminal branches are superficial and deep peroneal nerves here at the ankle level that we can block separately. A vascular puncture is quite rare because it's not in the same compartment. So indications for this block is operations on the knee, on the shin, on the foot, or on the Achilles tendon. And there are many different approaches that have been described in the past for sciatic nerve, the posterior approach, lower approach, parasacral, subtrochanteric, front approach. But I will talk today about the lateral popliteal approach. So skin innervation is this, as I said, it's mainly posterior innervation, depending on the approach. Sciatic nerve body position is on the back or on the side with the leg bent at the knee level. It doesn't have to be 90 degrees. As long as it's bent, and you can put the probe underneath, ultrasound probe. Insertion depth is not too deep, but you still need a longer needle because the bulk of the muscles there is quite big, so you need a long needle. I would use 100 millimeter needle again. In plane approach. 15 to 20 millimeters of local anesthetic. Target is the division of the tibial and common peroneal nerves, division of the sciatic nerve. So we scan from the popliteal fossa up. Okay, so here is our ultrasound anatomy. This is common peroneal nerve. This is tibial nerve. This is a popliteal vein. This is popliteal artery. Again, here is like a snowman or a traffic light, nerve, vein, artery. So again, these three structures underneath each other. Vein, artery, nerve. All right, let's do the technique. Okay, so this is how it's done. This could be a little device that can help you position in the leg. Complications, problems, the same as for all the other nerves blocks. The height of the sciatic nerve division varies greatly, so you may sometimes scan up and up and up until you see. And if it's too high, then the femur, the thigh is quite large. So I then give up and block them separately. So the hydrosection of the artery improved the search for the sciatic nerve. So sometimes inject around the artery and you will see how the nerve then emerges. The position should be comfortable for the doctor and the patient. It could be quite a longish procedure. I think I'm finishing in time. Again, thank you for your attention. And again, please visit my YouTube channel. Uh, Comment, like, subscribe. You're always welcome. There are a lot of videos there already, including lots of videos for regional anesthesia, short and small presentations. And again, if you are sitting the European exam, have a look at this book. It's quite useful. There are a lot of good reviews of this book, and those who sat the exam found this extremely useful. It's got 24 chapters in the book, and it covers the structure of the exam, lots of MCQs for part one, and lots of scenarios for part two for when you sit in your oral part of the examination. Thank you very much, dear colleagues. Дякую за увагу. Wish you good work with the rest of your course today. Thank you.